Hello, everybody. My name is Lulu Achua. I am going to be explaining the on the skill on how to insert a nasogastric tube and nasogastric suctioning, as well as the care of the NG tube, the NG medication, care of gravity, and pump feeding. During the insertion process, or before the insertion process, I make sure I verify the order to be sure I have the right order and to be carried out. Uh, there are various reasons why people do have the NG tube being inserted. Some is for medication purposes. Some is because the patient might be unconscious and cannot tolerate feeding by mouth. So the NG tube helps them to receive their food, their water, and medication. Others is they have issues with their digestive system. So whatever things goes through the mouth, they throw up. So because they've been so sick, then the NG tube also comes in to help them receive their food and their medication. And so when this with this done, I have to explain. I have to identify my patients with a two form of identifier. I ask them to tell me their first and last name and their date of birth. While that is done, I cross check with their armband. I perform a hand hygiene by washing my hand with soap and water for over 20 seconds. I introduce myself and I explain the procedure to the patient. The patient has the right to understand at every given point what you're going to do to them and why you are doing it to them. And then I gather my supply or equipment. When I gather my equipment, I have to assess the following before the procedure. I assess the history of the nasal and surgery or deviated septum. I assess for the presence of a gag reflex. Also assess the potency of the nasal of the nares, and then I examine or assess the patient's mental status to be sure they are able to cooperate with the procedure. And then I also make sure I check the size of the tube before I insert it. Make sure it is the right size that can fit appropriately. Then I have to place the patient in the higher Fowler position. I prepare a clean, dry work area at the bedside. Then I warm the tube with my hand to make it more flexible. I don a clean pair of gloves. I also make sure I measure the tube for appropriate insertion, the length, and the mark. I mark the tip of the nostrils to the tip of the earlobe, um, so that I know I am working on the correct and the side and the correct length. I mark with tape and measure the length for documentation purposes. After that, I lubricate the tip of the NG tube with water soluble lubricant. Then I um, I give the patient water to hold, and then I get the MSC's basin. I give the patient water to hold and I supply them with MSC's basin in case they want to throw up, because sometimes it can be irritating. I insert the tube appropriately into the nares at the correct angles. If the tube meets resistance, I have to take it out and then gently insert it again. Once the tube reaches the oropharynx, I'll ask the client to tilt their head forward and forward to their chest and start sipping the water. Advance the catheter when the patient swallows. So as they swallows, I advance the catheter. I continue to coach the patient to mouth breathe and swallow. And then I access the tube in the back of the throat to ensure it is coiled. To ensure it is not coiled. Because if it is coiled, then there's a kink in, it cannot go through. I make sure while inserting the tube, I will never force it. You don't need to force the tube. You insert it gently, gradually, until it goes nicely. So in the process where you are inserting it and it doesn't go through anymore, you have to discontinue and remove the tube. Then you get ready to do another insertion. I also make sure I verify the correct placement. I aspirate the stomach contents and check pH. I verbalize that the patient will also need to go for x-ray. I have to let them know that they have to go for x-ray. I apply Lopez valve to prevent leaking. Anchor tube to the nose and fasten to gown. I discard any soil supplies. I remove soiled gloves and wash my hands. Then I assist patient to a comfortable position. Once this is done, I attach the tube to low intermittent suction. For the external feeding administration, I also I provide privacy. I wash my hands. I introduce myself and the procedure to the patient. Then I gather my equipment. I also have to identify the patient, like in every step, every procedure you are doing, the basic steps are the same. Wash your hands, gather your supply, introduce yourself to the patient, provide privacy, explain procedure to the patient, and then you start the procedure. Not forgetting that you have to document at the end of every procedure as well. So I also have to put on clean gloves. I check the tube feeding solution to ensure the correct formula is given, the expiration date, and then I calculate and prepare the dosage appropriately. I review any pre-administration assessment information. I inform patient what is being given. I perform abdominal assessment. I elevate the head to 30 degrees. I discontinue intermittent suctioning. I verify tube placement with pH paper. I check for residual if the feeding is not going anywhere. I check if there is a blockage. And then I explain why. So if there is a residual in it, maybe the tube is smaller, maybe the tube is coiled in the inside. Those are the reasons why the food might not go through. Some of the reasons. Either the tube is blocked from old a previous feeding. So before every feeding, you have to clean the tube. Then flush the tube with appropriate amount of water, and then perform a feeding to gravity. Remove the plunger from a 30 to 60 ml syringe. Attach the syringe to feeding tube and pour measured amount in. You pour the required amount in, and then you have to regulate the rate of the flow by raising or lowering the height of the syringe. Then I assess patient on how they are tolerating the feeding. Don't just feed and go. You have to feed, monitor, watch. until they are comfortable. Then you can leave. Then keep checking on them. Make sure the feeding is going on well. The patient is tolerating it. The content, the drops, the number of the flow rates. Let me use that word. The flow rate is accurate, and then you when that is done, you document the intake and how the patient tolerated the feeding. Then when administering medication through the NG tube, you confirm the medication orders and time medications are due. Prepare order to the MA 3 times. When removing from the drawer, you have, so the 3 steps are: when you remove it from the drawer, when placing medication in the cup or syringe or administration device, before administering the medication to the patient. So those are the 3 steps or 3 procedures to verify the medication before administering. You calculate the dosage of the medication to be given. You perform you provide privacy to the patient. You perform hand hygiene. You introduce yourself and explain the procedures to the procedure to the patient, and you gather your equipment or supplies. You identify the patient, making sure it's the right patient, and with the two by identifying the patient, you are using the 2 forms of identifier, which is asking them their first and last name, then their date of birth. While they're doing that, you also verify with the name band. Make sure what they are telling you correspond with their name band. And this is mostly for conscious patients, because an unconscious patient cannot tell you their name. So for unconscious patients, to identify them, you check the name on their wristband, you check the picture on the MA and correspond with their picture of the person you're seeing, even though sometimes that may not tally. But you also confirm the name on their wristband, date of birth with what you have in your MA. That is how it's done for unconscious patients, since they cannot tell you their name and date of birth. You have to make sure, as you administer the medication, you have to follow the 6 rights of medication administration, which is the right drug, the right patient, the right dose, the right time, the right drug, right patient, right dose, right time, right frequency, and right documentation, right route, and right documentation. So you have to educate the patient on the name of the medication, the possible side effects, and the reason for the medication administration. Then you put on clean gloves. If the tube is running, stop infusion to give medication and turn it back on later. In the case where the patient was already having feeding going on, you have to stop the feeding first, before you administer the medication. Then once that is done, you turn back the feeding on. If suctioning is running, the same process, stop the suctioning, and you tell the patient you're going to stop the feeding, the suctioning. You give them the medication, then you turn back the suction on. You verify tube placement, ensure patency of the tubing prior to administering medication. Crush medication one at a time and mix with a small amount of water. Connect a large syringe to end of the NG tube and push through each medication. Flush tube with 5 ml of water between each medication. Explain what to do if medication cannot be crushed. If the medication cannot be crushed, you dissolve it in water. I think that's a procedure. You don't crush. If the medication cannot be crushed, I think if the medication cannot be crushed, you dissolve it, or you put it you put it in a tube, and you push it in bit by bit with the water. It will dissolve and goes in. You continue the process for each medication until all the medications are being given. And you keep the head of the bed elevated for 1 hour after you administer the medication or even the food, so that the feeding or the medication does not come back out the tube. Document fluid intake and medication administration at the end of it. Then you check your orders for now in the case of to remove the NG tube. So check the order for the removal of NG tube. Make sure you have the right order. Don't remove a tube for a patient whose tube is not supposed to be removed. And then you do the same process by providing privacy, washing your hands, introducing yourself and the procedure to the patient, gather your supply, you perform abdominal assessment, place patient in an appropriate position that is 30 to 45 degree, and then you give patient the emesis basin and tissues. In case they want to throw up, they use the emesis basin to throw up in there, and then the tissue to clean themselves. You put on clean gloves. Sorry. Discontinue suction and separate the tube from suction. Detach the tube from the patient's gown and carefully remove the tape from the patient's nose. Check placement and flush with 10 ml of water. Kink the tubing with your fingers. Then you tell the patient to take a deep breath and hold it. Quickly and carefully, you remove the tube while the patient holds their breath. Check the end of tubing once removed to ensure it is intact. It is intact, so that it's not cut and part of it is inside the patient. Then you dispose on tube properly following the policy. Discard used supply, remove your gloves and wash your hands. You offer the patient oral care. Let them let them rinse their mouth or wash their mouth. You help with provide nasal care, and also you provide any comfort that the patient needs. They have, so that they'll be comfortable after the procedure. You document how the patient tolerated and drainage and collective device. You document what was done, what was given, and how the patient was able to tolerate the procedure, and if there was any drainage. You document all of that. Thank you.